Please.
Good. Your time starts now. You are sitting in an MDT. A 65-year-old female presented with history of smoking and visible hematuria. Flexible cystoscopy showed a solid bladder lesion. Subsequently, she underwent uneven full TURBT. The histology is G3pT2 TCC of the bladder with muscle involvement, obviously. And she's quite fit otherwise. So how are you going to proceed?
So I will see this patient in a specialist bladder cancer clinic with a nurse specialist and explain the outcome of the MDT and the histological results confirming a muscle invasive bladder cancer. I'd like to know the full staging results of this patient. If she hasn't been staged, she requires a staging CT thorax abdo-pelvis to exclude any metastatic disease.
Okay, so what kind of imaging you are arranging?
CT thorax, abdomen, and pelvis.
Okay.
With a urographic phase.
Good. Her staging is normal. How are you going to proceed?
So in the absence of any evidence of metastasis, this lady has muscle invasive bladder cancer. She's 65. She's a very fit lady. And so the MDT will recommend a radical treatment option for this lady in the form of neoadjuvant chemotherapy plus either radical cystectomy, which can be done robotically or open, or radical radiotherapy.
Okay. She wished to discuss the bladder preserving strategies. What is the role of it?
So the role of bladder preserving strategy is mainly radical radiotherapy, which is at clinical equipoise with cystectomy. The specifics of this will be discussed by the oncologist who gave radical radiotherapy. However, I can tell the patient that this will preserve her bladder. There is a potential risk of radiotherapy effects to surrounding organs like the bowel, resulting in diarrhea or radiation proctitis. She will require ongoing cystoscopy surveillance following the initial treatment. So this would be the main things to discuss with her for the bladder preserving strategy.
Okay. After understanding the pros and cons, she is happy for radical cystectomy. How are you going to prepare her?
So I will counsel her with the aid of a Bowles information leaflet. I'll explain to her that radical cystectomy involves removal of the bladder. This also involves pelvic lymph node dissection, as well as urinary diversion, which could be a continent urinary diversion or an incontinent urinary diversion. I will explain to her the risks, including infection, bleeding, damage to major pelvic vessels, risk of urinary leak or lymph leak or lymph collection, risk of bowel injury due to anastomotic leak, which may require major laparotomy down the line. I'll explain the risks of anesthetic risks, and given that this is major surgery, risk of clotting the legs, clotting the lungs. However, she will have a session with the anesthetist as well to discuss in details about this. I would also make sure that she has a session with my cancer nurse specialist and the stoma nurses to discuss stoma care and go through sessions before the operation proper.
Do you aware of enhanced recovery protocol? What is the role in radical cystectomy?
So enhanced recovery protocol is a protocol which is in place now for major surgery across all surgical specialties. From a urology perspective, this involves optimizing this patient preoperatively and ensuring that the patient commences physical activity as soon as possible after surgery, and also instigating early introduction of diet following surgery. So it's a process to ensure the best outcome following major surgery.
Okay. How will you prepare her from the cardiology and pulmonary point of view?
So, from a cardiology and an anesthetic perspective, a careful anesthetic review as well as a C-PET testing assesses this patient's suitability for major surgery. And depending on this, recommendations will be made either for this patient to go to high dependency units or indeed to avoid major surgery if they're not fit enough for it.
Okay. What is the CPEX testing which you mentioned?
So this stands for cardiopulmonary exercise testing, where a patient attends and usually goes on an exercise bike, and the oxygen requirement and CO2 production is calculated, and an anaerobic threshold is also calculated for the patient, and all these parameters are interpreted to assess fitness for surgery.
Okay, so you are preparing her for surgery. So what is your major steps in the surgery?
So this will depend on if it's open or robotic. I am familiar with the robotic cystectomy approach with ileal conduit urinary diversion. So this patient will, in an appropriately prepped and anesthetized patient is kept in a Trendelenburg position up to 30 or 35 degrees to move the bowel away from the field of surgery. The ureters are identified and the bladder is dissected out. And given that she is a female, the anterior vagina goes as well with the bladder. Following on from that, pelvic lymph node dissection is performed, and then an ileal conduit is formed where a piece of distal ileum is isolated and anastomosed to the ureters, and the terminal end is brought out as a urostomy or a stoma.
Which part of ileum you will harvest?
So I will isolate, I'll measure 15 centimeters from the ileocecal junction and isolate a 15 centimeter segment of terminal ileum.
Why is that?
So preserving the most distal part of the terminal ileum is important because that is the point of absorption of important minerals as well as vitamin B12 and iron.
Okay, regarding lymph nodes, how much you are going to dissect?
So the boundaries for pelvic lymph node dissection in cystectomy include external iliac group of lymph nodes, obturator group of lymph nodes, internal iliac and the presacral.
Okay, do you know various types of lymph node dissection?
So there is the standard and extended and super extended levels of lymph node dissection. What I've mentioned is the standard. The extended may go up to the bifurcation of the aorta, and the super extended goes up to the abdominal aorta.
So when will you plan extended or supra-extended lymph node dissection?
So if the imaging suggests a lymph node outside the true pelvis, then one may consider an extended or super-extended lymphadenectomy. However, the consideration if there is lymph node extension to this point is whether surgery is now curative, and it should be carefully discussed and decided in MDT before going for that.
What is your view on orthotopic neobladder in women?
So, orthotopic neobladder can be considered if the patient is young and doesn't have any contraindications, for example, impairment in kidney function or previous significant incontinence. So if in the absence of these contraindications, orthotopic neobladder can be considered in women, they need to be motivated to perform self-catheterization after the procedure, and have the dexterity for that as well.
Okay, so how will you construct the orthotopic neobladder?
So this is done with a 60s. I am familiar with the Tudor technique, which involves isolating a 60 centimeter segment of the distal ileum after preserving the most distal 15 centimeters, detubularizing it and creating a neobladder, which is anastomosed to the urethra as well as to the ureter.
Yeah, the time is over now. So you can explain that there will be a chimney constructed in which the ureters are implanted, which will avoid a little bit of ureteric reflux also. Well done. Again, this is the advanced stage of the bladder cancer presentation. The other contraindications of orthotopic neobladder is the patients with hydronephrosis, patients with hepatic dysfunction, and also patients who have bowel disease like Crohn's disease or ulcerative colitis, that has to be included. And the terminal ileum, vitamin B12 along with minerals. B12 is more important compared to minerals. And enhanced recovery protocol, again, more of mobilization and early morning glucose challenge that has proven to reduce the unnecessary, it gives the enough raw material for the metabolic challenge what the patient is going to head on. And removal of the nasogastric tube early, DVT prophylaxis, mobilization which you mentioned. CPEX, I think if I'm correct, I asked you and then you brought in, so try to bring in CPEX as a part of enhanced recovery protocol as a part of your pre-op preparation directly.
Okay, yeah.
This group of patients, when you're discussing histology in the MDT, G3pT2 CIS, it is nice if you ask the pathologist to do PDL1 staining. That will be useful for any neoadjuvant immunotherapy. We haven't discussed neoadjuvant chemotherapy because of lack of time, but it will be also useful in future in case if the patient is having a recurrence or presenting with metastasis. PDL1 staining of the initial TURBT specimen will be very handy. This kind of answers will really make the examiner to think, okay, you have sat in the MDT and you have made the decisions also. Good. Well done.
Thank you.
And orthotopic neobladder in women is not straightforward compared to men. Again, the contraindications are like tumor in the bladder neck, involving the urethra, etc. Patient should be aware of need for intermittent self-catheterization, as you mentioned, dexterity. The main thing is the urethra is not as supportive in a woman compared to men. That's why neobladder orthotopic is challenging. And if you say robotic, there are people who are now advancing towards creating orthotopic neobladder robotically, but you can say, I will do the radical cystectomy part and then make a small incision to reconstruct the neobladder or for the ileal conduit. Good. Any things you want to add?
No, I think you've introduced the more advanced ones, which is actually helpful to discuss them because and would I be fair to say that the exam can actually go that far?
Yes, definitely. What we have discussed today is definitely exam questions. In fact, there will be more questions on neoadjuvant chemotherapy, advantages and disadvantages of that, advanced bladder cancer trial, and maybe like neoadjuvant immunotherapy also, because it's quite nicely evolving. There may be some questions on CIS. What is CIS? Why CIS is different from TCC? Why it is important? And response of CIS to BCG will be discussed separately.
It's very useful, very good session actually. Because bladder cancer is especially when it goes to the muscle invasive one. A lot of discussion can be generated. As you clearly did now, so thanks for that.
The other things in the MDT is you should go through the operative notes to make sure the surgeon is happy that the lesion is completely resected, because there is a good evidence that even though it is G3pT2 muscle invasion proven, if there is a residual disease, it is advisable for patients to have a TURBT whether the
Okay.
patient goes for radiotherapy or neoadjuvant chemotherapy with radical cystectomy. And there are studies which have proven that a good TURBT with neoadjuvant chemotherapy and radical cystectomy, especially if the radical cystectomy shows no cancer, those patients will have excellent outcome, because we are going one step above what is involved. You need to think like how we do for penile cancer, lymph node involvement. If the lymph node is involved to one level, we'll try to dissect one level up. And then if that level is involved, we need to go for the one level up till we get the normal lymph nodes, like that. So if the TURBT itself clears the tumor, and then if you do a radical cystectomy, that means the patient's cancer clearance and cancer specific survival and overall survival both will be much better.
Yeah.
Good. Well done.
Thank you.
Good. Thank you for joining today. Hopefully we will do one more interesting table in the next few days. I will send you the WhatsApp message.
All right. Thank you very much. Bye-bye. Bye.
Welcome.